And we are back with our pathology review. We're looking at neoplasms. This is the second section, our review of notes, lecture notes and books and what have you. And we're trying to make sense of all this. Anyway, let's begin with a definition or a description of benign versus malignant neoplasms. So very simply, benign tumors, let's say for example, an adenoma of the glands or a tumor of the glands, or for example the thyroid, they are normal looking or well differentiated. Um, they have colloid filled thyroid follicles. So that is an example of a tumor that is benign, well differentiated, and generally grows slowly. But how about if we have malignant tumor? So now we're talking about adenocarcinoma. So for example, with an adenocarcinoma of the colon, we have cancerous glands that are irregular in shape and size and do not resemble the normal colonic glands. So it is differentiated because the gland formation can be seen. Anyway, what's happening here is that we may have cells here that range from well differentiated to undifferentiated, which is anaplastic. But they are growing rapidly, and the more or the less differentiated they are, the worse that it gets. That's just a basic message here. So to understand neoplasms even more, we should know about whether there is or is not invasion. And later we'll talk about grading and staging, but generally we should know that for benign neoplasms, it is local, there is no invasion, and there is no metastasis. But for malignant neoplasms, they are invading the surrounding tissue, so there is metastasis. I'm just looking at two slides here. I'm noticing here, it says here for this microscopic view of a fibroadenoma of the breast, the fibrous capsule delimits the tumor from the surrounding tissue. So there is separation here. It's not spreading. However, on the other side, we see a microscopic view of the breast carcinoma and illustrates invasion of the breast stroma and fat by nests of cords of tumor cells. So here we see an absence of a well-defined capsule. So this should be noted. So we see a lot of spread. Just looks like a big mess. So I was reading earlier about these different types of tumors, and it can get very confusing, but as a general definition here, we can separate them into tumors with mixed differentiation. So mixed tumors, for example, pleomorphic adenoma of the salivary gland, carcinosarcoma. Another example here, another section, teratomas. What are teratomas? So these are comprised of cells from more than one germ layer, and they arise from totipotent cells, which can be anything, usually gonads and teratomas. These are benign cystic teratomas of the overall ovary is the most common teratomas. I was looking in Google and putting in teratomas and seeing examples of some very, very interesting examples of how one type of cell is in another cell. You see hair and teeth in the heart or in different organs, and they're in the wrong places. So these are teratomas. And I mostly get these confused with hemaratoma or choriostomas. Anyway, let's talk about aberrant differentiation. It says that these are not true neoplasms. So with a hemaratoma, this is a disorganized mass of tissues whose cell types are indigenous to the site of the lesion, for example, a lung. With a choriostoma, this is an ectopic focus of normal tissue. So for example, pancreas or perhaps endometriosis. So I get confused between teratomas and choriostomas and hamartomas. Anyway, it looks like things are in the wrong place. So, but that the teratoma is a neoplasm, but that the aberrant differentiations are not. So what does aberrant mean? Aberrant means deviating from the proper or expected course. Okay, I think I'm going to come back to that. It's getting a bit confusing. One example of a choriostoma, for example, would be hair in the pancreas. Okay, some misnomers. Malignant liver tumor. What's that? Hepatoma. Malignant skin tumor. Melanoma. Malignant testicular tumor. Seminoma. Malignant tumor of the lymphocytes. Lymphoma. So what can be known about the tumor growth rate? Well, generally talking about doubling time of tumor cells, this lengthens as the tumor grows. So with 30 doublings or 10 to the 9th cells, we might have 1 gram. And this may take from months to years to grow. But with 10 more doublings, we could have a tumor that is heavy as 1 kilogram, and this would be a lethal burden. So what is the fraction of tumor cells in the replicative pool? So what percent of the cells are actually actively replicating? Maybe only 20%, even in rapidly growing tumors. So we think about tumor stem cells and the rate at which tumor cells are shed and lost. Think about apoptosis and maturation. So at any time during the growth of the tumor, you would have a bunch of cells who are doing different things. So you may have some that are non-antigenic, some that are invasive, some that are metastatic, some requiring fewer growth factors. But we basically have, transformation, progression, proliferation of genetically unstable cells, and tumor cell variants and heterogeneity. So when you look at a schematic representation of the tumor growth, you can see different stages in cells doing different things. Some of them are dying, some of them are growing, some of them metastasizing, some of them are not. So I'm looking at a picture here of a comparison between a benign tumor of the myometrium called a leiomyoma and a malignant tumor of the same origin called a leiomyosarcoma. It's leiosarcoma. And I can see on the left side, you can't see this picture, but I'm looking at an ovary which is benign, a leiomyoma, and then looking at a tissue sample and small, well demarcated, which means it has clear boundaries, slow growing. It's non-invasive, non-metastatic, well differentiated. But on the other side, with a malignant leiomyosarcoma, it's large, poorly demarcated, rapidly growing with hemorrhage and necrosis. And this is locally invasive, metastatic, and poorly differentiated. So there we have it, is quite clear. And looking in first aid, I was looking at the statistics concerning estimated cancer incidence by site and sex and the estimated cancer deaths by site and sex, and noticing, of course, for men we have, prostate, and for women we have breast cancer, very, very high. And then next we have lung, so for men we have prostate and then lung, and then for women we have the breast cancer, then lung. So this is the estimated incidence of cancer by site and sex, but for the cancer deaths, we have lung at the top. So for men at 31%, for women it's 26%. So talking a little bit more about statistics, statistics are just averages, and you can pay attention to them. And with evidence-based medicine, of course, we're looking at all of the evidence and making some conclusions, but also we have to remember that individual cases vary. But it's interesting to know that concerning sun exposure, the melanomas, there is 6 times the incidence in New Zealand compared to Iceland. And there is a lower incidence for black people from melanoma, and in comparison to white people, and so do the normal area, pigmented areas like areoli on white people. Smoking and alcohol abuse, body mass. Of course, smokers, those who are abusing anything, we're going to have some trouble, although we don't know the causes, but some of them are obvious. Body mass, overweight, 50% increase in cancer. Why? No idea. Nobody knows. But it seems obvious that someone who's very, very heavy, we're going to have undue stress on organs, and things are just not going to be normal and thrown out of whack, in my own opinion. How about environmental versus racial factors? Japanese immigrants to the USA. So there have been a number of studies following Japanese who in Japan, for example, may be eating well or eating a lot of miso or fish, and then move to the States and suddenly are developing different types of cancers. It's said that in Japan they have more gastric cancers, whereas in the States you have of course, you have heart disease and different types of cancers. It shows that Japanese moving to the United States are going to develop different types of cancers, but then as the children are produced, then those rates will change. Viral exposure, human papillomavirus, HPV and cervical cancer, hepatitis B virus and liver cancer, Africa and USA, Epstein-Barr virus and lymphoma. So concerning the Japanese immigrants to California, for example, from Japan, we were talking about the change in the incidence of various cancers with immigration from Japan and the United States provides evidence that the occurrence of cancers is related to components of the environment that differ in the two countries. The incidence of each kind of cancer is expressed as the ratio of the death rate in the population being considered to that in a hypothetical population of California whites with the same age distribution, and the death rates for whites are thus defined as 1. The death rates among immigrants and immigrants' sons tend consistently towards California norms. So there we have it, some of the differences we're seeing. Death rates in cancers as Japanese move to the United States. Very interesting. So just finishing up here, what are some of the predisposing factors for cancer? Age. Most cancers occur in persons greater than or equal to 55 years old. Childhood cancers, what are examples? Leukemias and CNS neoplasms, bone tumors. And how about genetic predisposition? Familial cancer syndromes, early age at onset, 2 or more preliminary relatives with cancer, which is the soil theory, and multiple or bilateral tumors. How about polymorphisms that metabolize? Procarcinogens, for example, nitrates, and non-hereditary predisposing conditions. Chronic inflammation, precancerous conditions, chronic ulcerative colitis, atrophic gastritis of pernicious anemia. How about leukoplakia of mucous membranes or immune collapse? So there we have it. We've discussed the basics of neoplasia, and I hope that I'm picking up some of it, but I think I need to do a lot of MCQs. Go back into the book. And thank you very much for listening.